Before I begin with this segment, I want to just put on the screen the basics of this whole video, which is that number one, acute kidney disease is diagnosed when the serum creatinine levels are higher than the normal range within an acute period of days to weeks, typically less than 3 months. That's the number one point. The second point is, one of the manifestations, the early manifestations of acute kidney disease is reduced urine production or oliguria. And then number three, in order to kind of zone in on or zero in on the cause of acute kidney disease, what we do is we calculate the blood urea nitrogen and then create a contrast as a ratio with the creatinine levels. And if the ratio is less than 20:1, that indicates there's a problem with the kidneys themselves, and then we have to investigate the kidneys. Otherwise, if it's greater than that, then it's probably either pre-renal or post-renal azotemia. And we're going to discuss the different types of pre-renal azotemia in this video. And it's pretty straightforward. It's going to be easy. So pre-renal azotemia is one type of acute kidney injury that usually occurs because of poor renal perfusion. What that means is that the kidneys do not receive sufficient blood flow. And the clinical term for poor renal perfusion is renal hypoperfusion. Obviously, when the kidneys do not receive sufficient blood flow, the glomerular filtration rate drops, which decreases urine production. And as explained earlier, decreased urine production or oliguria increases the metabolic wastes like creatinine and blood urea nitrogen. And we end up with kidney disease. A common and obvious cause of poor renal perfusion is a reduction in the intravascular volume. Okay, so that's basically medical speak for dehydration. Anything that decreases the blood volume. Now, this can include poor oral intake, not drinking enough water, severe diarrhea, or even vomiting. We call that emesis in medicine. And excess urine production, or diuresis. Diuresis typically occurs in hypertensive patients who are on diuretics to help control their blood pressure. Another intuitive condition that could reduce the intravascular volume is significant blood loss, or hemorrhage. Now, major burns can also result in significant fluid loss. It might seem surprising, but the skin normally locks in moisture. And so when it gets burn damaged, water rapidly evaporates from the body. And the larger the burn, the more severe this evaporation becomes, because the damaged tissue cannot retain the fluids. And burns don't just hurt the skin. They also fry the tiny blood vessels underneath the skin. Now, these vessels start oozing all the plasma into the surrounding tissue, which again evaporates rapidly, leaving less fluid in the actual bloodstream. Anyway, the point is that ultimately these conditions reduce the blood volume and therefore reduce the mean arterial pressure. What is the mean arterial pressure? Basically, it's the body's average blood pressure. When we measure the blood pressure, we place a cuff on the arm, and the machine then gives us two values, a systolic and diastolic pressure. These basically indicate the pressure in the arm when the heart contracts, systolic, and when it rests, diastolic. Then we use these values to estimate the mean arterial pressure. There's actually a formula for that, but that's not the point now. Consider the mean arterial pressure as the clinical term for the organ perfusion pressure because it basically determines the steady push that keeps blood flowing to your vital organs. It's basically the pressure needed to deliver the oxygen and the nutrients. So when the intravascular volume shrinks, the mean arterial pressure and the organ perfusion pressure will also drop. And guess which organ gets affected by the low pressure? The kidneys. So we go back to renal hypoperfusion. A less common cause of poor renal perfusion is an obstruction to renal blood flow. For example, if there's an atherosclerotic plaque, which is essentially a fatty deposit in the renal artery that builds up and then eventually ruptures and causes a thrombus. This can cause what we call renal artery stenosis. The narrow or stenotic artery gets narrowed by the cholesterol plaque or the thrombus, which in turn restricts blood flow in the renal artery, resulting in decreased renal perfusion. Another less obvious cause of renal hypoperfusion is decreased cardiac output, or basically heart failure. When the heart fails to pump properly, less blood is put out into the blood vessels, so which again reduces the mean arterial pressure and the organ perfusion pressure. This results in renal hypoperfusion. Notice, even though the kidneys themselves are fine. The renal hypoperfusion decreases glomerular filtration rate and therefore decreases urine excretion of metabolic wastes. So this results in pre-renal azotemia. Nevertheless, if the underlying cause is addressed right away and the kidneys get reperfused without delay, kidney function can usually be restored or brought back without permanent damage. In the next video, we'll talk about why the BUN to creatinine ratio is greater than 20:1 in pre-renal azotemia.